So flash forward, you are now continuing with the lumbar flexion examination. We've moved Hannah into a side lying position. We're going to examine passive segmental lumbar flexion. It's real important that when our patient lies on the table, they have not laid in a position where their lumbar spine is flexed. So you should see lordosis. And you have to make sure that the hips are at less than 60 degrees. Now, if you remember during the active motion video clip, one comment that we made was a term called lordotic retention may indicate instability. So as we do this passive technique, if our patient showed us lordotic retention, we want to be above their thighs and passively begin to flex their lumbar spine. Now we're not even going to palpate here. We're just going to look. If Hannah showed us lordotic retention in a standing position, but we're able to flex her lumbar spine in side lying, and you see kyphosis develop in her lumbar spine during this passive test, that's a clinical indicator that she was retaining that lordosis for one of two reasons. She had a very painful segment that did not want to move into flexion, and/or that painful segment was unstable in the direction of flexion. This is a non-loaded test, so oftentimes you'll see a difference between the standing active procedure and this passive procedure. One other comment about passive segmental flexion. It's a very helpful test for the L4-5 and the L5-S1 interspace, or motion segment. With the hips below 60, if we palpate at an interspinous space, first at 5-1, we make just a very small motion. We should not feel too much movement recruited into the L5 or the L4 motion segment. We should not feel too much separation of the spinous processes at either one of those segments if the segment's stable, if the disc joint is nice and strong. If, on the other hand, with just a small amount of hip flexion, the segment feels very loose and it moves a great deal, and that's a potential indicator of segmental instability.